So my topic today is androgen receptor antagonists, and I'm going to briefly go through some background. Fortunately, I get to follow Eleni, who's done a great job of going through the androgen receptor and its importance in prostate cancer. I'm going to focus on some of the clinical compounds that we've used, and then talk a little bit about future directions. So this is the prostate cancer clinical states model. It's really a framework for clinical practice and drug development. When patients are initially diagnosed, they're diagnosed with localized disease, at which time they're candidates for surgery or radiation. At the time of progression, patients develop a rising PSA, we call that a biochemical recurrence, or sometimes visible metastatic disease. And it's at this stage that patients are considered to be non-castrate, and we typically use drugs like combined androgen blockade using an LHRH analog in combination with an anti-androgen to produce a response. But this response, although it's durable, is usually not forever, and so that's what happens when patients develop castration-resistance disease. At this stage of the disease, patients progress despite hormonal therapy, and their risk of death from disease is greater than their risk from death of other causes. And because of that, this has been a great area of interest for clinical investigators in medical oncology. Up until really the past decade, we used to call this part of the disease program, or the castration-resistant area, hormone refractory disease, and I think we've talked quite a bit today and can see that that's probably no longer the case. But the clinical options available for medical oncologists in the castration-resistant state right now have, up until last week, been limited to cytotoxics and bone-targeted agents. Of course, now we have abiraterone, and we are all, I think, rejoicing. But even more important than the clinical significance of being able to give this to our patients in clinic is really the concept, which is that the androgen receptor is, in fact, relevant in castration metastatic disease. And that opens up an entire world of possibilities and combinations of drug therapies. So I really just put this slide up quickly. Again, Eleni, you've already spoke about the androgen receptor, but really the androgen receptor is overexpressed, and it's actually can be more frequent in castration-resistant disease relative to untreated primary disease. And what you're looking at here is androgen receptor expression, where the black lines represent androgen expression in a metastatic castration-resistant cohort. So again, the androgen receptor is actually more frequent in the castration-resistant state than it is in the castration-sensitive state. And again, that underscores the importance of the androgen receptor in advanced disease. So this is really a cartoon looking at some of the therapeutic targets of the androgen receptor signaling pathway. We've spoken about abiraterone earlier today, which involves adrenal and tumor synthesis of androgens. There's certainly phosphorylation or non-ligand dependent phosphorylation of the androgen receptor that can occur via other pathways, and chaperone proteins. But really what I'm going to talk about today are mutations in the androgen receptor and amplification of the androgen receptor that allow for promiscuous ligands and also contribute to the conversion of anti-androgens from antagonists, which actually block tumor progression, to agonists, which can actually cause cancers to grow. So this was actually one of the first compounds we used in the clinic. It's BMS 641988. Actually, it has a 20-fold higher affinity to the androgen receptor, and you can imagine that in a disease where there's overamplification of the androgen receptor, a drug that has a much higher affinity than bicalutamide would be useful. But what we're looking at here is a PSA waterfall curve, so that each line represents an individual patient. We treated about 54 patients in the United States and an additional 6 patients in Japan, and we saw some response in terms of PSA decline and some stable disease. But at the 60 milligram dose level, we actually saw there was actually a witnessed seizure in Japan. So in the setting of really moderate clinical activity and seizure, it was decided that this drug would not move forward in clinical development. But of course, we learn from clinical trials that are negative just as often as we learn from clinical trials with positive response. And when we took a look at the PSA curves for patients on this study to try and understand why the response wasn't as robust as we might have liked it to be, we did see what we would call anti-androgen withdrawal. So this is just an example PSA curve for a patient. He started BMS 641988 up here. His PSA declined. He started to progress. But when we stopped BMS 641988, he had a paradoxical decline in PSA. And this underscored the problem of agonist conversion with anti-androgens. So in thinking about a wish list for second-generation AR antagonists, we certainly need drugs that are effective in cells with high AR expression and that are resistant to bicalutamide. But we also need a class of anti-androgens that overcome agonist activity, and this is really critical for further development of this class of drugs. And finally, if you can do that, you'll probably need a novel mechanism of action for the drug, and thus motivation or MDV3100 was born. So at the time that BMS 641988 was being developed and abiraterone was being developed, Charles Sawyers, who was at UCLA at the time, along with Michael Jung and his postdoc, Samedi Ook, were looking at small molecule anti-androgens and trying to improve upon their efficacy in prostate cancer. So they found a small molecule that had a very, very high affinity for the androgen receptor. The problem was it still had agonist activity. So Michael Jung modified the chemical structure of this compound, and thus motivation was developed. So this is really sort of a schematic demonstration of what happens with the androgen receptor. In its unbound state, the androgen receptor is bound to chaperone proteins but no ligand. Typically binds to a ligand such as dihydrotestosterone. This causes a very dramatic conformational change. The androgen receptor translocates into the nucleus. This is where it binds to DNA and polymerase II and coactivator recruitment. The way bicalutamide works is very similar. It's a ligand. It binds to the androgen receptor, induces a conformational change. The androgen receptor does in fact move into the nucleus, but it doesn't bind to DNA, and it doesn't really recruit coactivators. Motivation is a novel androgen receptor antagonist because it overcomes this agonist activity. And one of the ways that it overcomes the agonist activity, again, it does bind, but it prevents or impairs some of the androgen receptor from getting into the nucleus. And that's a very big issue in terms of the efficacy of this drug. In addition, for a drug that does get into the nucleus, it blocks DNA binding and coactivator recruitment such that there are no agonist effects. And based on this drug moved forward into clinical testing. I should mention just a preclinical slide that shows some of this data. Of course, MDV3100 is active in AR-expressing cell lines, also tumor models, and you can see here RD162 is the precursor of the clinical candidate MDV3100, and you can see that it actually, compared with bicalutamide, induced tumor regressions in these mice models. But also, looking at confocal microscopy, you can see that with testosterone or bicalutamide that the androgen receptor moves into the nucleus. But with the preclinical candidate RD162 and MDV3100 itself, some of the androgen receptor remains in the cytoplasm of the cell. And again, that's a major way that this drug functions and prevents tumor growth. So the first in man phase 1/2 study of MDV3100 started enrollment in July 2007. It was run through the Department of Defense Prostate Cancer Clinical Trials Consortium and involved 5 other sites. What we saw actually within the first 6 patients who were enrolled at the 30 milligram dose and the 60 milligram dose cohorts was that all 6 patients had previously been treated with at least Casodex, and all 6 patients had a decline in PSA. This was, of course, very exciting, and so we moved forward to amend the clinical trial to include a phase 2 component very quickly, and this phase 2 component included 12 patients in the chemo-naive state and 12 patients in the post-chemotherapy state at each dose level as we were going through dose escalation. And I just want to underscore how really forward-thinking that was of the investigators, because at that time we didn't have abiraterone approved as in the post-chemotherapy state, and it really was, although we had a lot of preclinical data to support these kind of drugs for patients who had already received chemotherapy, it was really turned out to be very well thought through and really terrific for these patients. So just moving forward into the baseline characteristics of the drug, there were 140 patients that were enrolled in this study. And just drawing your attention again, about half the patients had received prior chemotherapy, and 25% of those had received maybe even 2 or more prior chemotherapeutics. This is the pharmacokinetics of the drug. The pharmacokinetics were linear. This slide here shows the steady state, and I do that really just to point out that already at 150 milligrams, we were seeing what was thought to be an efficacious dose in xenograft models of 10 micrograms per milliliter. And this later became important when choosing the phase 3 dose, which turned out to be 160 milligrams. This is a slide showing the grade 3-4 adverse events on the top and reasons for discontinuation of treatment on the bottom. And you can see at 360 milligrams and above, we started to get into some toxicities, notably fatigue in terms of grade 4 adverse events, but also at 360 milligrams and 600 milligrams, there was evidence of witnessed seizures in 2 patients and then an additional unwitnessed seizure at 480 milligrams. It's notable that all 3 of these patients were on drugs that were thought to lower the seizure threshold, but still concerning, particularly given the side effects profile of the previous drug that I had spoken about, BMS 64198, which also had seizure activity in a single patient. And so in moving forward, the company elected to use a dose of 160 milligrams in the phase 3 setting, which was extremely well tolerated in this patient population and also efficacious. This represents the MDV PSA curves. These are, again, waterfall curves so that each line represents a PSA for an individual patient. This is broken down by dose. And it does appear that at about 150 milligrams, there seems to be dose equivalence such that you're not getting a greater response at greater doses. But this is the slide it's my favorite slide, that shows the PSA decrease from baseline, or the maximum PSA decrease in this patient population. And it's broken down into chemo-naive and chemo-exposed patients, and again, shows just about a greater than 50% decline in PSA in both groups, which is really quite extraordinary. This is a time to PSA progression. I chose to show the Kaplan-Meier curve showing 25% increase over PSA nadir in keeping with Prostate Cancer Working Group 2 guidelines. And you can see here that it was about 32 weeks. But now that I've said all this wonderful stuff about PSA and how this is my favorite slide, I really have to be careful because we do know that patients on these kind of drugs do develop PSAs that start to rise. And it's probably inappropriate to take patients off study just because a PSA is increasing. And so this is just an example of one of our patients at Memorial who started treatment. This was his baseline imaging study with a PSA of about 212, and this was in January of 2008. In just about April of 2009, he had a PSA nadir of 8, and then his PSA started to rise, certainly well above 25% above the nadir. And you can see here that even all the way in July of 2010, when his PSA was over 80, he remained perfectly asymptomatic, and his scans really didn't look much different. So I think when we're thinking about this patient population and these kinds of drugs, we're going to be careful about how we measure response and how we measure resistance. And part of the Prostate Cancer Working Group 2 guidelines focus on progression, clinical progression, as opposed to response. And I think that's really important to remember. So this is radiographic progression in light of that. And in terms of patients with radiographic progression, the median time to progression was 47 weeks in all subjects. And again, you can compare that to the PSA progression, which was in 32 weeks, and that was quite a difference. Finally, just one of the, before I talk about future directions in this class of compounds, I just want to mention that we did use an exploratory agent called FDHT PET, which is fluorodihydrotestosterone. Essentially, you take dihydrotestosterone and you put a probe on it, and you can actually thereby image, or we believe you can image, the androgen receptor in that way. And you can see here, this is a typical FDG PET lighting up, and this is an example of an FDHT PET lighting up in the same place as the FDG study does. And when we biopsy the tumor, we do see AR expression. And in this study, we used FDHT PET imaging as an exploratory objective. We had 22 patients who underwent FDHT imaging, and this was spearheaded by Dr. Larson, who's the head of nuclear medicine at Memorial Sloan Kettering, and also Dr. Michael Morris, who's done a great deal of work on this on the clinical side. And what you're looking at here is FDHT uptake in the spine, and this is pre-treatment, and then post-treatment, presumably, because MDV3100 is binding to the androgen receptor and displacing the dihydrotestosterone, we saw resolution. And of course, that was a very exciting finding for us as well that we're still exploring. So based on these really exciting responses in terms of radiographic responses, PSA, exploratory, FDHT imaging, circulating tumor cells, this compound has moved forward into the phase 3 setting. In the post-chemotherapy stage, they call it the AFFIRM trial, and that's already close to accrual, and we're eagerly awaiting those results. And the pre-chemotherapy stage is still accruing, and we call that the PREVAIL trial, and we await completion of that study as well. In terms of future directions for this class of androgen receptor antagonists, I think it's going to be critical to interpret our correlative studies. I put here circulating tumor cells, PET, tissue, but of course bone marrow biopsies and other means by GEM models to inform for biologic predictors of response and resistance is going to be really critical. And this is because there's clearly a population of patients, I believe, that are resistant to this class of drugs that target androgen receptor. This is the PSA waterfall curve for abiraterone acetate, and I've superimposed the curve for MDV3100, and they look almost identical. Are they identical? I don't know, and I think we need to figure that out, and that will also inform how to sequence these drugs going forward. By looking not just at the patients who are responding, but trying to figure out, are the patients who are resistant, do they share similar characteristics? Do they not over-amplify AR? Is it CYP17? But what that may be contributing to these predictors. There's also a next generation of AR antagonists. Of course, as soon as you find one drug, you're moving on to the next set of drugs. One of these drugs is ARN-509. It's also been developed by Charles Sawyer's Aragon Pharmaceuticals. Gave me this slide to show. This is currently in phase 1, a phase 1 study, but I do believe it's moving into phase 2. And really just trying to show here the purple and blue represent ARN-509 at similar concentrations with the pink and red, which is MDV3100. And you can see here that at the same dose of ARN, here in the purple, there appears to be greater activity compared with MDV3100 at a lower exposure. And that may be critical in terms of moving this class of drugs forward in terms of toxicity. There's also another drug that's on the horizon. This is I believe, a different kind of drug than I've seen. It's an androgen receptor mRNA antagonist. This slide just shows the preclinical data showing that it down-modulates AR mRNA, but also AR protein. And so this is moving into clinical trials as well. I think combinations of AR antagonists and complementary signaling pathways are going to be important moving forward. And just to give an example of one that I'm interested in, it does look from some work by Brett Carver, who works with Charles Sawyer's. He lent me this slide, but it does look like PTEN-null prostate cancers may be relatively resistant to anti-androgen therapy. This slide just shows in mouse models that when you use castration with MDV3100 alone in PTEN-null models, there's actually very little tumor regression. But when you combine it with a PI3K mTOR inhibitor such as BES235, this is really optimized. And so I think this is a potential opportunity for future collaborations and evaluation. And finally, we've talked about this, I think, quite frequently today. Earlier clinical states, such as rising PSA and even clinically localized disease, are going to be very, very important in the future development of these drugs, and I know that we've already started to move these forward. So with that, I will conclude and thank everybody for their time.
Thank you so much, Dana. Beautiful talk, and it's really encouraging to me to see how many bright young people are moving into this field. And I include you in the bright young people, Oliver, even though you have a 20-year history. But I'm sure there are questions, so we have a few minutes here. Othan.
Hi, Othan Iliopoulos from Mass General. That's a question for you, and I'm sure also potentially for Eleni, who presented signaling. Despite the great advances in this AR inhibition, I think that this is a clearly new area here. Clinically also it becomes very clear that we have some short responses, that we have some regression of the disease. Does anybody know what signaling pathways mediate this post-AR blockade or AR independent, presumably, reactivation of a disease?
So I think I think you're asking what's mediating these responses in these non-AR mediated responses to these type of drugs. And I think we're only going to be able to understand that better as we do more correlative studies and look at the pathways. And it's probably not just going to be biopsies. I think we're going to have to look at a lot of different modalities, preclinical models, and actual patient tissue to understand that.
Ron,
Hi, Ron DePino. I'm wondering along the same lines, there are some patients that don't respond at all with respect to PSA up front. So do you understand what's different about those patients on the genetic level? Genotypically or even clinically, you know?
So these are all excellent questions, and if I knew the answer. But so, for example, Dan, some of the things that probably the best way I can answer this is to talk about some of the things that we're doing to understand that. And so Dan Danila, Howard Scher, they've been looking at circulating tumor cells using all sorts of different technologies to look at AR expression, compare them amongst the responders, the non-responders, and also to use the FDHT imaging to look at patients who appear to have AR blockade versus patients who don't. We do know that there are patients who had FDG PET imaging who had a response who didn't have a response on FDHT and vice versa. And all of that is obviously very provocative. And when we look at circulating tumor cells from those patients or when we have biopsies available from those patients and put it together, I think that will be very, very helpful. And we are working on that, but we don't know right now.
Yeah. Akash Patnaik from Bethesda Deaconess. In the patients that you looked at DHT PET responses with MDV3100, did those patients also get a corresponding FDG PET to see the impact? Because you would expect that with MDV3100 treatment, you may see no effect on FDG PET because you're upregulating the PI3 kinase pathway, and that goes back to the whole crosstalk question.
Yeah, it's a small number of patients. It's only 22 patients that we have these matched studies on, but it's really a mixed bag. It's hard to say anything definitively about the response. And there are multiple targets, and some targets look better, some targets don't, and they differ between studies. But we're also looking at the same FDG and FDHT PET imaging across a spectrum of different drugs. So, for example, we have a mTOR inhibitor in combination right now with IMCA12, and we have FDG PET, FDHT PETs in those two, thinking along the same lines that you might see a differential. And so really we are just waiting through all the data, trying to understand it.